So I have the great pleasure to introduce to you Professor Harry Sumnall from the Center of Public Health in Liverpool, John Moores University. The next talk is obviously about prevention. He has done a lot of things in prevention. He was part of the European Drug Prevention Quality Study. He is past president of the European Society for Prevention Research. Please take a seat, fast. And he has profound interest and experience with epidemiology and biopsychosocial factors in prevention. And Harry is going to talk about where now for drug prevention. Thank you, Harry.
Well, thank you very much for that kind introduction, Henrik, and it's been a really interesting conference so far. And one of the things that I've enjoyed about it is this multidisciplinary perspective, this true multidisciplinary perspective. Because many years ago, I started my career doing studies in rats, administering them LSD and MDMA. I didn't really have the patience to continue with that, unlike our scientific colleagues, neuroscientific colleagues. But even now, I've moved into the field of prevention and interventions in drugs policy. I think that training was absolutely critical for me to understand the broader context and broader concepts in relation to drugs. So I think this conference is really important and valuable by drawing those links together. I do think neuroscience and pharmacology have a lot to say to people involved in policy and in my specialism, prevention. So for my talk today, I'm mostly going to be asking questions, I think. Usually when I give talks about drug education and drug prevention, people want to know, well, what works? How do we prevent drug use? How do we reduce drug-related harms? I'm not going to cover that in this talk because I think there's lots of resources, lots of papers. There's going to be some parallel sessions after this talk which will address that. Maybe going to ask some broader questions, particularly in relation to some of the key themes of this conference about what is happening with new drug cultures, new drug policy, and how we should be responding to this. I'm going to be deliberately provocative in some places. You might not agree with everything I say. So if you have fans of drug checking in the audience, be aware. But that's going to be deliberate. It's going to ask us to be really critical about the sorts of work that we're doing and thinking about, for example, what is the evidence? What are the principles for our activities? Have we really thought about why we're doing these particular activities? I'm going to start off with a very simplistic definition of prevention. You might think, well, that's obvious. We want to prevent drug use. Well, actually, modern preventative thinking isn't about these classic primary prevention principles. We tried that in the 1980s and 1990s. It doesn't work. Modern prevention is actually focusing on the consequences of behavior. And that is the justification for a lot of the activities that we do. And in this sense, rethinking about prevention, about how people experience drug use, and maybe some of the problems for some of them, also allows us to incorporate important harm reduction principles as well. In my mind, prevention and harm reduction aren't mutually exclusive. They're part of the same continuum of action. So if in your discussion with policymakers or funders, and they're questioning perhaps why you're doing a particular activity, if they argue that what you're doing is harm reduction, you can also argue no. Harm reduction also has a really important preventative function. You're preventing harms and potentially preventing escalation to more harmful patterns of substance use. And this is why I'm interested in prevention, and this has underpinned a lot of my work. I also think we need to be honest, particularly if we're talking about why we're doing particular activities. So again, just my personal opinion, you might disagree. I do think cannabis is associated with a number of harms, particularly in young consumers. We have quite good evidence that the use of cannabis at younger ages is associated with more regular use and adult use disorders. We also know that early initiation of cannabis can also lead to co-addiction of tobacco. To me, that's the number one public health problem with cannabis, particularly in Europe, co-addiction with, or even sole addiction with tobacco. But also as well, I think, even though it tends to dominate a lot of the public and policy debates, we do need to be realistic and we do need to be careful about potential mental health impacts of cannabis use, particularly for vulnerable young people and vulnerable groups. This is not to say that all cannabis use is harmful, but I think you can make valid and justifiable arguments that we should at least be delaying the age of initiation in young people. And I mentioned at the beginning they'll be mostly asking questions around prevention. And prevention has been described by some authors as an ideological litmus test. Essentially what they're saying is how we respond to different forms of drug use is also an indicator about how we view and respond to certain people in our society. And prevention has also been described as a way of controlling and defining problem people. This is important because how we think about who uses drugs also determines what sort of activities we use in response to them. If you have a group of drug users, whatever the drug is, and as a society, you view those people on the outsides of society, if you view them as deviant, if you view them as lawbreakers, if you view them as immoral, then that provides a justification to essentially to do whatever you want to do to that population, whether it's through legal enforcement or whether that's due to preventative interventions. So we need to think about why are we doing a particular activity? Why are we pursuing a particular approach, and what positive benefit do we want to gain by doing this? I think there's also another consideration we need to take into account, and this is actually that I was just reflecting on the talk by Professor Hines yesterday, and of course he's a very eminent addiction psychiatrist, and he comes face to face with a lot of clinical populations, individuals who experience real problems with drug use and substance use. And one thing which really struck me is towards the end of his talk when he spoke about what were some of the most important determinants of individuals experiencing harm from drug use. Yes, he recognized that drug use was important, but it was also the environment in which those people grew up with. So in the study that he cited, he focused on poverty and neighborhood factors. And I've often thought that, well, we focus a lot of our attention and a lot of our focus when we're thinking about responding to drug use. We maybe focus on drug laws. We maybe focus on developing new interventions. But actually, the most effective preventative response is probably a political response. And I think many of us in the field, for various reasons, don't really engage in that political process. Although it's very, very easy for me to say this, the number one preventative activity which we would recommend is reduction of poverty, retaining young people in school, jobs and opportunities. Now, of course, that's very easily said rather than done. But I think that when we're thinking about, well, how do we approach this tough issue of drugs? How do we ensure about what we're doing reduces harms and doesn't cause these inequalities and social and health exclusions? That we need to look at the broader political picture. So I would say to you, if you're interested in drug policy reform, make sure that you're also engaged in the wider political process as well. And I think especially for young people, that this is exceedingly important, which is why that in many European countries, the low participation of young people in the political process, despite a great interest in drug policy reform, is rather unfortunate. A few other considerations. I'm not going to get too technical, but this last one I think is really important, and it echoes those thoughts that I raised just then. That when we think about our preventative responses, we need to understand and recognize that they don't take place in a vacuum. Well, what do I mean by that? Here's just a simple example. This is data from the Global Drug Survey. Hello to Larissa from the Global Drug Survey. You can't really see it well here, but this is just looking at patterns of co-use of tobacco and cannabis. Now, this is international data. It's a non-representative survey, but it illustrates the point nicely that when you're thinking about young people's cannabis use or adult cannabis use, here we have the proportion of individuals reporting consuming cannabis in a joint. So you might think, well, yes, let's focus on cannabis use, but look underneath that. 70% of them are also consuming their cannabis alongside tobacco. So if your actions are only focusing on the cannabis component, reducing the harms from the cannabis, what are you actually doing about tobacco use as well? Tobacco use is certainly more harmful. So thinking a bit more cleverly about how we're responding. Now, this is a very simple example. When we're thinking about the real determinants of health and the complexity in health and how we respond to that, it can get a bit overwhelming. So this is a great slide. I always try and use this slide. Yeah, so this is an action plan developed by the UK Government Office for Science to tackle obesity. So in order to address obesity, well, we need to understand food consumption practices, but we also need to understand food production, and we need to understand consumers' access and affordability of different types of energy-rich food. We need to understand, for example, social psychology about how people engage with their food. What is the impact of gender and body image? We also need to look at the physical environment. Okay, you can pass sugar tax laws, you can you can deliver interventions which promote physical exercise, but where are these activities taking place? If you're in a city in the UK, for example, it's really, really dangerous to go out on your bike and cycle around the city. But in many European countries, cycling is normalized. And this is an example of that if you're interested in improving health, think about the wider system. Now, there has been no similar model developed for drug use, illegal drug use. So if any of you want to get a nice PhD or a European Council funding grant, there's an idea for free for you. That's obviously ridiculous, but just to reflect that when we're responding to drug use, like other health issues, think about the bigger picture, because what you're doing on one component of that overall model might actually be negated by other barriers or even facilitated by other opportunities in the system. Now, for those of you like me from a public health background, will be very, very familiar with the so-called socio-ecological model of health. Very simplistically, this is suggesting that good health is not just related to individual choice and individual action, but it's also an important interface between our relationships with others, our family, our friends, our communities. But then there's also structural factors, neighborhood factors. I mentioned poverty beforehand. And I think a lot of the preventative work that we've done so far has tended to focus on this side. So a lot of the interventions we have are about education, providing knowledge, developing life skills, so-called life skills. They're very important. I think there's been less attention paid to these things further upstream. And in the rest of the talk, I am going to focus on maybe some of the public policy elements. What is the policy environment? What are the norms? What is the state of affairs set by national policy in which we deliver these activities, in which we intend or hope to improve health and reduce harms from drugs? Very little attention has been paid to this. The wider environment is really important. Luckily, looking at economic figures, and certainly in some countries in the European Union, we're now seeing a recovery from economic recession, but this illustrates it nicely. So this was a very recent study which was published looking at the impact of the European economic recession on the prevalence of drug use in young people. It estimated that increases, I think the estimate here was an increase of 1% in regional unemployment was associated with a small but significant increase in drug use. And this really reflects my earlier point nicely, that if we're thinking about, okay, what impact are our interventions, our preventative interventions going to have, bear in mind wider determinants of those health behaviours. What happens when you don't do that? It often means that our response is uncoordinated, it's fragmented, and often we don't have a cohesive policy. Now, if you're like me and you've been working in the drugs field for 20 years or so, particularly in prevention and the treatment field, often people are excited by interventions. They get really excited by interventions of working with young people, working with population groups, and making a difference. That's great. That's a good justification for doing that work. But actually, I think more of the important work, but to be honest, quite boring work, is around how do all of these different approaches fit together? How can we improve cohesion between, for example, mental health services, child protection services, drug services? How do we actually make that work better? And I think in one of the parallel sessions, Gregor Burkhardt might be addressing some of these issues. So when we're thinking about prevention and responses to drug use, let's not just focus on the interventions and those immediate outcomes, but are we actually thinking about what's taking place behind the scenes? Another issue, I'm not going to dwell on this too much, is that for those of us working in the field, it's often a struggle with finance and decision makers. For many reasons, it's very difficult to make a cost-effectiveness case for prevention. This is important because in most countries, certainly in the United Kingdom, we're trying to deliver these activities against a background of reduced budgets. Now, it's probably fair to say that those in the treatment field face their own challenges, but it's often easier to make an economic case for drug treatment because of the very immediate health, crime, and social costs. Individuals who are experiencing problematic substance use are usually involved in crime, they're at high risk of overdose and death, etc. It's relatively easy to make an economic case for investment and action. So in the United Kingdom, as you can see there, the second bullet point, an often repeated statement is that for every £1 spent on drug treatment in the UK, you save £2.50 in societal costs. Now that is a powerful economic message. You can say to policymakers and you can say to politicians who are accountable to the electorate and are accountable to the Treasury, acting with this group, you may not approve of their behaviours, it can save you money. And that wins votes. It doesn't work the same way with prevention. You're often talking to policymakers, but making a case that actually the benefits that you'll see will be in 5, 10, 20 years' time when they're no longer in office, they're on the international public speaking circuit or a director of a company. They may not care about this. So it's often very difficult to make that economic case. But I think we need to try. These are some of the challenges. I'm not going to talk about these in too much detail because they're quite specialized to the prevention field, but maybe just highlight a few of those which I think are perhaps important. Today, if I have time, I'll talk about multiple risk behavior approaches, which I think is probably the way forward, in my opinion. And I also say something very quickly about the differences between prevention, education, and harm reduction. But maybe just reflect, and this has really been inspired by many of the other talks that we have in the conference, particularly some of the discussions earlier today. And this is how we need to rethink prevention in the face of a changing policy environment. Now, for example, if this is data from the SPAD survey, so this runs every 4 years, about 100,000 young people across Europe take part, aged 15 and 16 years of age. So it's the largest young people survey in the world, I think, certainly in Europe. So interesting things are happening. We know, for example, that if we look at, this is prevalence rates in the different I've given my big reveal away there. So here we have prevalence rates on the y-axis in 2015 and there on the x-axis 2011. There are some country differences, but overall, the rate of cannabis use in Europe in young people has pretty much remained the same. You know, slight fluctuations, but it's relatively stable. In a lot of countries, it's decreasing. But actually, when we look at adult treatment data, the number of presentations in connection with problems related to cannabis use, and there's lots of discussions about the exact nature of those problems, but certainly looking at raw data, there's been an increase in the number of people presenting to treatment services for cannabis. So even though general population prevalence is pretty much the same or has not moved greatly, the number of so-called problematic cases, or the number of individuals requiring treatment, has increased. Now, this is really interesting, and this is really important, I think, when we go on to discuss and think about some of the justifications and some of the implications of cannabis law reform. If we think about very basic economic principles, so for most consumer goods, we know that around about 20% of the population will consume 80% of the product. And that's certainly true of a lot of the epidemiological data that supports that for cannabis as well. So we need to think smartly and carefully about what potentially are going to be the impact of drug law reform, cannabis law reform in this particular, on that really high-risk group. Now, in the UK at the moment, we're facing a crisis, really, in terms of the number of people dying from drugs overdose. We contribute in Europe, the UK contributes, and it's not boasting or bragging here by any means, we contribute a third of the burden to drug-related deaths. And this is an important background and important context, that when we're thinking about responses to drug use, it's actually most of our focus should be ethically, morally, and from a health and scientific perspective on those highest risk individuals. I often think maybe that those of us, including myself, who argue for drug law reform, need to also think carefully about how does this law reform help and contribute to reducing inequalities in those really high-risk groups. And I think a lot, at least, of public discussion about drug law reform doesn't take this into account. This is a wider discussion, I do appreciate that. So while societal views changing, the relevance of this will become apparent in a moment. Slowly but surely, yes. So the Eurobarometer survey, it's commissioned by the European Union. It takes place every few years, and every few years they look at drug use issues. It's basically an opinion survey. And they've been asking young people aged 15 to 24, what do they think about different drug laws or different responses to drug use? There's been a decrease, but there's still a majority of young people who favour tough responses to drug use. Now, that might surprise you in many ways, because young people are meant to be less conservative. Young people apparently are meant to be more accepting of progressive policy. But we need to bear in mind that most young people in Europe are still against the idea of drug law reform. Diminishing, and I think, in fact, a majority will be in favour in future years, but this is an important thing to bear in mind. We also know that there's variation in how individual countries are responding to cannabis use. So we heard this morning, for example, that in the different regions of Switzerland, very, very different responses by police services. And for those of you who follow the drugs debate internationally, there's often reference to, for example, what's happening in Portugal with the dissuasion committees. Now, this is very interesting. You know, most people who go to the dissuasion committee after a low-level offence in Portugal, no further action is taken. But there are some people who do receive further action. But what is that action? What is the objective of that action? Or what is the impact of that action with regards to helping that individual or helping those groups? I'm reminded of some data which emerged from France of a similar sort of intervention which was delivered a few years ago, where upon arrest, individuals, I think it might have been their first or second offence, they were diverted into drugs education and prevention. And they evaluated what was the effect of this. And actually, the effect of this intervention was not to have any impact on drug harms or future drug use. Actually, the impact was that those people who received it modified their behavior with regards to getting caught. So if we are offering these alternative approaches as we're moving along the road towards drug policy reform, are we actually thinking about why we're doing this? What do we want to achieve from it? What is going to be the impact? I'm very transparent. I'm somebody who's very much in favour of new ways of thinking about drugs. This was a report I was involved in for a minor UK political party who lost loads of seats, but and I'm not politically affiliated, but the reason why I'm highlighting this is in this particular model that we presented, we spent a lot of time about how do we fit in these broader issues of education and prevention in a regulated model. If we look at some of the international discussions about the justification for drug law reform, lots of different, I'm not going to rehearse these, you're all probably very familiar with all these different arguments. But I'm going to highlight some which I think are important. Well, first of all, and this is, lots of these have been emerged from some of the debates in the United States, where, interestingly, different states had different arguments and different positions about why they wanted to have different approaches to cannabis, or marijuana, as they would call it over there. In some states, campaigners argued, well, cannabis is harmful and therefore should be regulated by responsible authorities. It shouldn't be criminals who regulate the availability. The state should be regulating it, so the state can intervene and potentially reduce harms. And then neighboring states, people were actually basing their campaigns on the fact that cannabis isn't harmful, or it's associated with similar harms to alcohol, and we allow alcohol, so why not allow cannabis? So some conflicting messages there. Other arguments, cannabis use is enjoyable, people should have the right to use it without being punished, to protect young people from criminal markets, to reduce availability and access to youth. Many different arguments, we can go into the pros and cons and the accuracy and sustainability of many of these. But it reflects actually the way that new policy has been presented potentially has an important influence on social norms around cannabis. That's what it's intended to do. That's the whole point of it. And in my analysis or my ongoing analysis, I hope to publish on this soon, is actually looking at the justification and content of a lot of these new regulations around cannabis. Very, very little consideration has been made about what new cultures are these policies creating, and have we developed relevantly sophisticated and responsive education and prevention interventions. So just on a very simple basis, so most models, for example, include age restrictions. This is usually equivalent to alcohol age restrictions. Well, what happens to young people who don't have access to a legal market, who are underage? Are they suddenly going to stop wanting to use cannabis? Are they no longer going to have the desire to use cannabis? I argue, no, that's not going to be the case. But maybe from a more sociological, maybe from a more philosophical perspective, and I know that we have anthropologists in the audience, does policy change also transmit and shape these new norms around use? And are we actually saying, depending upon how the policy is framed, that drug use is a legitimate form of practice, of a legitimate form of identity transmission? It's useful in instrumentalization in various forms. So how are we going to respond to this? And there was a really nice paper in the International Journal of Drug Policy earlier this year, and I recommend, I can send you the reference if you're interested, begun to raise questions about this. How do we develop new preventative responses in this new policy environment? And if we're thinking about a new norm, new cultures around drug use, now this opens up new questions as well. So we're just thinking about alcohol here, of course. And we know that with alcohol, yes, associated with health and social harms, but now there's a broader societal discussion about the role of alcohol in nightlife, gender representation, Some of the research that we've done in Liverpool, we've argued that there's the pornification of nightlife, which has implications for respect, has implications for safety, but also has implications for the effectiveness of those nightlife interventions we're delivering into this cultural environment. So if we're having new drug policy and new drug law reform, we're changing the culture. Are we responsive? Do we know what that culture is going to become? And how can we develop interventions in response to that? Thanks. I'm very aware of time. I do have lots more slides, so I can certainly send you the slides. Something else which I think is really important that we need to think about. Of course, we've heard about the fantastic work which has been taking place internationally around the medical utility of currently illicit and previously stigmatized drugs. A well-known graphic, so ecstasy tablets saving someone from the traumas of PTSD. We know all about the research with psilocybin mushrooms. Fantastic work which has taken place in LSD with regards to LSD, the prominence of certain cannabinoids, for example, as a treatment for seizures. This also, from a cultural perspective, raises a few interesting questions, I think. And certainly I know in some conferences there's been quite a vigorous and quite a heated debate about what this actually means for progression and development of culture around drugs. Now, I for one, certainly, I'll hold my hand up, I certainly support scientific research and the development of therapies. But what does this actually mean about how society legitimizing certain forms of drug use, medical forms of drug use? And what does this mean about our discussions and our responses to non-medical forms of drug use? So is the psychedelic renaissance only really relevant to certain forms of knowledge and certain forms of practice? And how do we integrate that in our responses? And I can't, I will wrap up, but I can't finish this talk without at least a nod towards some of the quite bizarre publicity around microdosing, for example. This reminds me, I can just about remember some of the popular marketing and popular publicity around Prozac and fluoxetine in the late 1990s. Almost universally, stories around microdosing have been positive. To my mind, there's been no real discussion about what this actually means with regards to drug cultures. Many people have concerns, for example, about repeated use of 5-HT2A and 2B receptor agonists on the heart. And also as well, another issue, most of the discussion has been taking place with regards to Silicon Valley or free enterprise or venture capitalists. What does this also mean about our cultural response? Very aware of the time. As you can see, I had lots of other talks. Yeah. But, hopefully I've presented my view that we're living in a changing world, new challenges that we would never have predicted with regards to education and prevention. So how are we going to respond to those? Are our existing approaches good enough? And I would have said a bit more about that if I'd had time, but thank you very much.
Thank you very much. Thank you, Harry, for asking all those questions and having the courage to ask us all of those questions. We have a few minutes for asking questions to both of our presenters. So please, if you have questions. So I think we should take a microphone up there. Do we have the other microphone? Then, yeah. Maybe, Nils, you can shout a little bit. Oh, you've got the microphone.
Hello. I have a question to Mr.
Closer to your mouth.
Time, yes, concerning the opiate substitution treatments. Do you have data or some impressions about the mortality of comparing substitution treatment with a full agonist and partial agonist like buprenorphine? Because I think that lots of the patients die from the full agonist treatment, and they are out of the statistics. And this is nobody really talks about this mortality and the burden of people dying in treatment.
No, we do not have this in Germany. We had an old study in the beginning of 2000 that clearly found out that substitution treatment leads to a decrease in mortality overall. And there are some studies internationally, I think also part of the global burden of disease studies that confirm this finding, but I'm not aware of studies who differentiate between total or agonists and partly agonists. I'm not aware about this. But it's a treatment, of course, which prevents from dying. Of course, but it's mostly not has something to do with the treatment, but of factors outside the treatment. So it's a very rare. Well, we have these torsades de points, these problems with the QT, prolonging effect in your heart. So we had this, and I think some long-term problems with osteoporosis, I would say. But usually, if a person is dosed on, for example, methadone or buprenorphine for a certain while, it's hard to die from the same substance due to the concentration blood level. So that's...
So thank you. Maybe we can bring up that debate again in the panel later. We've got a question up there.
Thank you very much for the interesting talks. My question is, you showed us a slide about cannabis patients entering treatment for the first time. And you also mentioned earlier that you think the most dangerous kind of cannabis use is with tobacco. Now my question is, are those two related? Is there an increase in patients entering cannabis treatment because they smoke cannabis together with tobacco? Or is there any significant data on cannabis and tobacco use at the same time?
I think the simple answer is no, there is no data, large amount of data on that. It's certainly worthy of investigation. I would actually argue that, at least from a UK perspective, and I can only speak to the UK, that one of the issues for many years is that because historically our treatment services have been set up to respond to opiates and crack cocaine, that cannabis use was tolerated. It would be the view of drug treatment workers that, at least they're not using heroin or crack, so cannabis is okay. So to a certain extent with tobacco as well. But I think also, and again from a UK perspective, that there's a very little understanding about the reasons why people are presenting. If you look at referrals, yes, there's going to be people with dependency issues, but certainly for younger populations, it's often to do with, for example, offending behaviour. And you could argue, is that a product of the legal environment, etc.? Maybe issues with mental health and housing, breakdown in social relationships. So people enter treatment for a whole variety of reasons. So I think that it's certainly not from a UK perspective simply an issue of dependence, but that cannabis is part of a wider spectrum of issues that those individuals are facing, and potentially cannabis is making it harder for those individuals to respond to that wider and deal with those wider biographical issues.
So thank you. Unfortunately, we've got no more time for the questions now. We need to move into the break and into the tracks. I'm waiting for a very interesting panel later in the afternoon. Okay.